Good morning, I'm Dr. Priyadarshini, Assistant Professor from the Department of Biochemistry. So I'll be discussing the biochemical basis of alcoholic liver disease now. At the end of the session, Phase 2 MBBS students should be able to describe bilirubin metabolism, interpret liver function, distinguish between direct and indirect hyperbilirubinemia, describe the biochemical basis of alcoholic liver disease, and enumerate the biochemical investigations related to alcoholic liver disease. So to understand the development of alcoholic liver disease, we need to know the bilirubin metabolism and the alcohol metabolism in detail. So as we know, bilirubin is the end product of heme catabolism. So bilirubin is formed in the reticuloendothelial cells of spleen and bone marrow, which is water insoluble. This water insoluble bilirubin will bind with albumin, reach the hepatocytes of the liver. There it gets conjugated by the hepatic conjugation system. The UDP glucuronide transferase enzyme will conjugate the water insoluble bilirubin, that is unconjugated bilirubin, to conjugated bilirubin, which is water soluble. This conjugated bilirubin is now taken up by the biliary canalicular system, and the bilirubin enters the bile. The bile, which is secreted into the duodenum, carries the bilirubin. So here the bilirubin will be deconjugated to urobilinogen as it reaches the colon. The intestinal microflora there in the large intestine will convert the bilirubin to urobilinogen, which is later converted to fecal stercobilinogen. A part of urobilinogen by the process of enterohepatic circulation will be reaching the circulation and reach the liver. Then it is sent to kidney again, and there from there it will be released in the urine. So urobilinogen can be seen, some amount of urobilinogen will be seen in urine also. So this is the bilirubin metabolism. Now let us see how we can differentiate the three types of jaundice based on the bilirubin findings. There are three types of jaundice: prehepatic, hepatic, and posthepatic. In prehepatic jaundice, that is hemolytic jaundice, there is excess load of bilirubin formed from the hemolysis of RBCs, and the conjugation system cannot handle the excess load. So there is a defect in the conjugation. So there will be excess of unconjugated bilirubin, and the conjugated bilirubin will be normal. In the urine, we cannot find bilirubin and bile salts in prehepatic jaundice, whereas urobilinogen, stercobilinogen will be found in the prehepatic jaundice, in the prehepatic or hemolytic jaundice. In case of posthepatic jaundice, the problem is not with the conjugation. The bilirubin, conjugated bilirubin, is obstructed. The bile flow is obstructed, so the conjugated bilirubin cannot be released into the intestine. So there is excess of conjugated bilirubin, whereas the unconjugated or the indirect bilirubin will be normal. And the urine will have bilirubin and bile salts. Urobilinogen will be absent in the urine, and fecal stercobilinogen will also be absent in case of posthepatic or obstructive jaundice. So the spectrum of alcohol disease, if we see, it is not a single entity. So a healthy liver progresses to a fatty liver or steatosis, then a state of inflammation, steatohepatitis, which then progresses to fibrosis, and then cirrhosis and hepatocellular carcinoma. So the alcohol can induce steatosis to steatohepatitis, fibrosis, cirrhosis to hepatocellular carcinoma. So altogether it is called alcoholic liver disease. Let us first see how alcohol is metabolized in our body. Alcohol, there are two pathways. The major pathway is by alcohol dehydrogenase system. So this is a constitutive enzyme. So alcohol will be converted to acetaldehyde, and this acetaldehyde will be converted to acetate by another enzyme, aldehyde dehydrogenase. So there are two main enzymes here, alcohol dehydrogenase and then aldehyde dehydrogenase. So there will be a change in the NAD-NADH ratio, where excess NADH is generated in the in case of alcohol, when alcohol is metabolized. The alternate pathway is it is metabolized to acetaldehyde by microsomal cytochrome P2E1 enzyme system. So that also will result in the formation of acetaldehyde. So the metabolites acetaldehyde and acetate are formed from alcohol metabolism. How alcohol induces steatosis, this fat deposition in the liver. So this NAD-NADH ratio will be altered when a person consumes alcohol. So there will be less of NAD and increase NADH levels in the hepatocytes. This will result in decreased fatty acid oxidation, increased fatty acid synthesis, and impaired lipoprotein assembly and excretion. So these events will result in accumulation of fat in hepatocytes. This is complemented by the peripheral catabolism of fat, that is lipolysis. This also will increase the circulating pool of fatty acids and eventually lead to accumulation of fat in the liver. So alcohol induces steatosis. Alcohol can also induce inflammation and result in alcoholic steatohepatitis. This is by different mechanisms. So the main byproduct or the metabolite of alcohol metabolism, acetaldehyde, will result in formation of chemical adducts, which in turn releases or produces neoantigens, and that will induce the immune system. So there is an autoimmune response in response to the new antigens produced by the acetaldehyde. This will result in hepatocyte injury. The protein adducts formed from acetaldehyde can also induce oxidative stress and lipid peroxidation, which can induce hepatocyte damage. The alternate metabolizing pathway, that is by the microsomal cytochrome P2E1 enzyme system, that can also result in the generation of reactive oxygen species. Alcohol is known to impair methionine metabolism, which will reduce the glutathione. Glutathione has an antioxidant activity. So this will, when these levels are reduced, it is going to result in excess oxidative stress. So this in turn leads to hepatocyte injury. Alcohol will also increase the permeability of gut for the bacterial endotoxins. So this will induce the hepatocytes Kupffer cells and induce an inflammatory response, resulting in alcoholic hepatitis. How alcohol induces fibrosis? Once the inflammation has set in, once the hepatocytes, Kupffer cells, endothelial cells are inflamed, they will result in release of cytokines and chemokines, the growth factors, transforming growth factor beta, which in turn will activate the stellate cells. So what are stellate cells? Stellate cells are the cells that store vitamin A. They are going to be dormant until the inflammation sets in. Then they will transform into fibrogenic cells and we will start laying down collagen fibers. This fibrogenic cells will have myofibroblast-like contractile property, which can contract the sinusoidal vessels and will result in the increased vascular resistance, and thus perfusion can also be altered or deranged. So this will everything will eventually result in the development of hepatic fibrosis. So what are the investigations, biochemical investigations that we can do in alcoholic liver disease? So in case of fatty liver or alcoholic steatosis, we can find that triglycerides and cholesterol levels will be elevated and mild or non-specific elevation of bilirubin and the transaminases and alkaline phosphatase enzyme. In case of alcoholic hepatitis, the bilirubin will be elevated. Normal, it can be it will point it. So the level of bilirubin here will be more than 3 mg per deciliter. Both the direct and indirect, conjugated and unconjugated bilirubin will be elevated. AST-ALT will also be elevated, but they will be less than 400. AST-ALT ratio will be more than 1. ALP and GGT, there will be modest elevation. And a marker of chronic alcohol use, that is CDT, carbohydrate deficient transferrin, will also be increased. In case of cirrhosis, when the alcoholic hepatitis progresses to cirrhosis, uh, there is a bit of change in the investigations. There will be more of hypoproteinemia, hyponatremia, folate deficiency will be there, and prolonged prothrombin time, because the clotting factors are synthesized by the liver. Uh, there will be deficiency in the clotting factors, and hence prothrombin time will also be prolonged, in addition to the LFT findings like AST, ALT, transaminases, bilirubin will also be elevated. High GGT and ALP can also be seen.